I've been one of the original adopters of the Trabectome technique, and I found it to be extremely useful in managing glaucoma patients in my practice. I think it has a good wide variety of applications in different forms of open angle glaucoma. It can be performed as a standalone procedure in patients with high intraocular pressure. It can be performed in patients that have combined cataract procedure at the same time. And it has very good efficacy in both of those scenarios.
One question that I'm often asked by other surgeons is, what is your ideal first patient? And I think one should not so much worry about the stage of the disease, but rather have a patient with an easily identifiable meshwork, pigmented trabecular meshwork. If you don't choose such a patient, then you might have a hard time to identify the target structure when you're beginning to learn angle surgery, and you might even potentially ablate the wrong tissue, the ciliary band, for instance. So it makes it much easier to see it nicely outlined by a little pigment.
Huge number of patients that are a candidate for this procedure and can benefit from it. I mean, everybody always wants to flip around and say, well, what about the guy who's got the 0.9 cup and is the visual field and split fixation and needed pressure at 10? Well, they're not a candidate. But that's not most of our practices. Most of our practices are filled with patients that maybe have small visual field defect, cups of 7 or 8, somewhere in that range. They're going to have cataract surgery anyway, and it marries perfectly with cataract surgery.
For me, the patient that I like to use for the Trabectome are typically patients with mild to moderate open angle glaucoma that are on 1 to 3 medications that are undergoing cataract surgery. So that, to me, is the perfect patient. I will tell you, for me, a lot of times the driving factor, actually, interestingly, is the cataract, because they're complaining about their vision, they're on multiple medicines. However, there are times when glaucoma drives that decision as well, where they're just not well controlled or they're non-compliant. And then the Trabectome would be a good choice there.
The ideal candidate for Trabectome, I've found, is someone who has a coexisting cataract and is already on maybe 1, 2, maybe 3 medications, or someone who's newly diagnosed as a glaucoma who's on no medications and they also have a cataract. Because I found the most success in patients who are phakic, who either have their cataracts removed in combination with the Trabectome, and I've also found very good success in patients who are pseudophakic and just need the Trabectome procedure alone.
You know, my idea of the ideal Trabectome patient is actually expanding, and it continues to expand. You know, I used to think it was initially just people with mild glaucoma that needed a modest reduction in their intraocular pressure. And then as I became comfortable and as I started to see nice results, I expanded it to mild and moderate glaucoma with little tweaks that I performed in my technique, both intraoperatively as well as the postoperative management. I was able to continue to get really good results and even great results, to the point where I've now expanded my indications to even include some patients with advanced glaucoma.
The beauty of these surgeries is that the eye is not really damaged. It's a safe way of achieving your goal.